Hi everyone. Hope all of you would have done your NEET PG exams very well. So in this context, let us recall some very important pharmacology MCQs that were asked in your NEET PG 2023 exams. Myself, Dr. Padmanabha, TS. Let's move on to the MCQs. So coming to the first MCQ. So the first MCQ is a 50-year-old patient was having a psychotic symptoms, started with drug A. Patient got no improvement by haloperidol and thioridazine. This new drug A causes increased salivation, hyperlipidemia, sedation. So which of the following drug was the patient shifted onto? So they are asking about the drug A. So drug A is causing increased salivation, that is increase in the siluria. So there is a hypersalivation. There is a hypersalivation, and also there is a hyperlipidemia. There is a metabolic syndrome involved. Metabolic syndrome involved. So what would be the answer for this question? So it is very simple. It is a direct question. So please remember the answer is the clozapine, which is a atypical antipsychotic. So the answer is the clozapine, which is a atypical antipsychotics. So clozapine, as you know, it is a atypical antipsychotic, and the hypersalivation or increased in the salivation, it is also called as wet pillow syndrome. Wet pillow syndrome. So wet pillow syndrome is the name which is given due to the symptom of hypersalivation. So it is also called as siluria. So apart from that, you need to remember a very important aspects with respect to clozapine is. So please remember it is a drug of choice in case of resistant schizophrenia, which can take care of both the positive symptoms as well as the negative symptoms of the schizophrenia. And also the clozapine is associated with the side effects such as myocarditis, metabolic syndrome, as you saw, hyperlipidemia, and also it is associated with agranulocytosis, which requires a constant monitoring of the blood levels to detect the agranulocytosis. So for the first question, the answer is clozapine. So coming to the second question, uh, hypertensive patient on multi-drug therapy for hypertension presented with chest pain, and the ECT showed the alt T wave changes. So some of them said that there was a ECG which was given which showed the tall T wave changes. So which drug might have precipitated this condition? So they're asking which of the following drug is causing the tall T wave on ECG. So please remember, so here hydrochlorothiazide is a diuretic agent which belongs to the thiazide groups of drugs. Metoclopramide is a beta blocker, and spironolactone is a potassium sparing diuretic, and amlodipine is a calcium channel blocker. So among this, the drug which can cause the tall TVA changes is the drug which is going to cause the increase in the potassium levels. Increase in the potassium levels. So which of the following drugs will increase the potassium levels? So all of you must have got this right answer. So the answer is the spironolactone. Spironolactone, which is the potassium sparing diuretic, that is the aldosterone receptor antagonist. So here the right answer is the spironolactone. So why not the hydrochlorothiazide? Hydrochlorothiazide and loop diuretics, both loop diuretics and thiazide will decrease the potassium levels, even though the metoprolol can increase the potassium levels. The increase in potassium levels are very negligible. So for this question, the answer is spironolactone, which can lead to T wave changes in the ECG due to increase in the potassium levels. That is the hyperkalemia can cause T wave changes. So spironolactone is a potassium sparing diuretic which increases the potassium levels, which is responsible for the T waves. And the decrease in potassium levels are seen with the loop diuretics and the thiazide diuretics. There will be hypokalemia, and even the metoprolol can increase the risk of hyperkalemia. The risk is very less. It is less than 0.5%. So here the better answer will be the spironolactone, which has got hyperkalemia. So next, moving on to the third question. So which of the following drug inhibits the area which has been marked at site 1 and site 2? So they're asking the drug which can inhibit both site 1 as well as the site 2. So means the drug has to inhibit the neutral endopeptidase as well as the angiotensin converting enzyme. So what could be the drug here? So please remember, again, this is also a direct question. So if you could remember, omapatrolate is the correct answer, which can inhibit both the neutral endopeptidase as well as the angiotensin converting enzyme. So these inhibit both the enzyme activities. So what about the sacubitril? Sacubitril is also called as neutral endopeptidase inhibitor or neprilysin inhibitor. Whereas losartan is the AR based. It is a angiotensin receptor blockers. What about neseritide? Neseritide is a BNP analog. BNP analog. Please remember it is a BNP analog. So here the answer is the omapatrolate, which inhibits the activity of neprilysin as well as the ACE. So as you can see, the sacubitril is a NEP inhibitor, which is also called as neprilysin inhibitor. Please remember this. Both are similar. Losartan is the angiotensin receptor blockers. Neseritide is the BNP analog, and omapatrolate is the one which will going to inhibit both the angiotensin converting enzyme as well as the neprilysin. So one more thing you should remember is the RB. What is RB? So AR stands for angiotensin receptor blockers, and NI stands for neprilysin inhibitors. So ARBs here is the valsartan, and neprilysin inhibitor will be the sacubitril. It is called as ARNI, which is a combination of valsartan and the sacubitril. So coming to the fourth question. A patient on chemotherapy presented with thrombocytopenia. Please remember the patient presented with thrombocytopenia, that is the decrease in the platelet count. Which of the following drug will be preferred in this patient? So you need to increase the platelet count. So how we can do is, so please remember, you see here, we have four options: darbepoetin, filgrastim, oprelvecin, and sargramostin. So most of the times you have heard about the filgrastim and the sargramostin. So where this filgrastim is used, filgrastim and sargramostin, they are mainly used in case of leukopenias. So basically, the filgrastim is a granulocyte colony stimulating factor, whereas the sargramostin is the granulocyte monocyte colony stimulating factor. So here the right answer is oprelvecin, which is the interleukin 11 analog, which is a recombinant form. So it will going to stimulate the thrombopoietin growth factor. So whereas darbepoetin is a erythropoietin analog. Darbepoetin is a erythropoietin analog, which will going to increase the RBC synthesis. So for thrombocytopenia, the drug is oprelvecin. So as you can see, darbepoetin, it's erythropoietin analog, which is used to increase RBC. Filgrastim, it's a granulocyte colony stimulating factor used to treat the leukopenia. Oprelvecin is an interleukin 11 stimulant, which will going to activate the thrombopoietic growth factor, thereby they increase the platelet levels. Sargramostin is a granulocyte monocyte colony stimulating factor, which can also be used in leukopenia, similar to the filgrastim. So in the question, the answer for this question will be the oprelvecin. Along with that, there are thrombopoietin growth factor analogs or thrombopoietin agonists. Like you have romiplastin, we have eltrom bag, as well as lusotrom bag, etc. So coming to the fifth question, a child went to a playground and child has consumed certain fruits, and child has presented with confusion, increased body temperature, and urine retention. So all these symptoms are mimicking what? So all these symptoms are going with the Anticholinergics. So here, what are the anticholinergic? Anticholinergic, please. Yes, atropine. It is atropine, or you can go with the datura. So datura. So and also what they have asked is select the correct option in this case of poisoning. Which case of poisoning? It is a datura or atropine poisoning, not the organophosphorus. So this is ruled out. This is ruled out. And it's antidote, they are asking antidote. So for atropine overdose, what will be the antidote? It is physostigmine. For datura poisoning, the antidote will be the physostigmine. So here the answer is datura and the physostigmine. So you will not use neostigmine, will not use praloxam. So atropine, praloxam are used in treatment of OP compound poisoning. For this question, the answer will be the datura and physostigmine. So datura will lead to atropine poisoning. The drug of choice is the physostigmine, whereas in case of physostigmine overdose, you need to remember the drug of choice will be the atropine. So coming to the question number 6, patient was on dialysis, presented with the vomiting, tremor, and muscle cramps, and some of the visual disturbances. So what could be the drug which can be used for management of this patient? So please remember, whenever the patient goes for the dialysis, if the patient experiences such symptoms, it is mainly due to the dialysis equilibrium disequilibrium syndrome. So dialysis disequilibrium syndrome, and which will be characterized by vomiting, muscle tremor, muscle cramps, and visual disturbances. The right answer here is dialysis disequilibrium syndrome can be managed by giving a mannitol. So here the right answer will be your mannitol. It is your mannitol. Nesiritide, you already saw it. It was a neprilysin inhibitor which was used in the treatment of chronic CHF. So next, coming to the question number 7. A patient has got a hyperthyroid with a neck swelling and is asthmatic also, and is not taking the asthmatic medication, but he presents with anxiety, restlessness, blood pressure was very high, 180 by 110 mm of mercury, and pulse rate of 120. It is tachycardia and ECG suggestive of atrial fibrillation. So when you look at this case, so what is the first thing you need to treat? So we need to go with the emergency thing. So which is the emergency thing? You need to take immediate action here, not the thyroid swelling, not the uh, restlessness, anxiety. So mainly you want to treat the emergency condition first in this patient. So here the emergency thing is the atrial fibrillation. Atrial fibrillation. So how do you treat atrial fibrillation? So you cannot give a propranolol here. So propranolol is not given because he's an asthmatic individual. He's asthmatic individual. Propranolol will lead to bronchoconstriction. Will lead to bronchoconstriction. So it is not used. And also the esmolol is very short acting cardioselective beta blocker, but even though it is a cardioselective, there is some component of beta to blockade which can lead to bronchoconstriction. So propyl thiouracil is mainly a anti-thyroid drug of choice in case of thyroid storm. So basically it is a case of thyroid storm. So propyl thiouracil will be the anti-thyroid drug of choice in case of the thyroid storm. So here the preferred drug will be the diltiazem, which is a short-acting calcium channel blocker, which can take care of the atrial fibrillation. So esmolol is a short-acting cardioselective beta. Even it can act on beta-2 receptors and it can lead to bronchospasm. Propyl thiouracil is preferred anti-thyroid drug, which is given in thyroid storm, whereas propranolol is totally contraindicated in asthmatic patient and can block the beta-2 receptor as well. So propranolol is a non-selective beta blocker. So diltiazem is preferred here because of its short-acting calcium channel blocking activity. So next, coming to the question number 8. So patient was on digoxin therapy, developed a toxicity, and level of digoxin was 4 nanogram per ml. So at 4 nanogram per ml, the patient has developed digoxin toxicity. So how much time will it take to reach a therapeutic plasma concentration, considering the therapeutic plasma concentration is 1 nanogram? So the toxicity is occurred at 4 nanograms, and they're saying digoxin therapeutic plasma concentration will be 1 nanogram. grams per ml. And off-life here they have given is the 40 minutes. Usually the off-life of digoxin will be the around 40 hours. Here they are given 40 minutes. So what could be the answer here? So digoxin has got a narrow therapeutic index which requires the therapeutic drug monitoring. Let us see how it can be done. So as you can see, there is a 4 nanograms. So 4 nanograms will be converted into 2 nanograms in 40 minutes. So it is a 1 off life. Again, the 2 nanograms will be converted into 1 nanograms in another 40 minutes. There is a 2 off life. It takes 2 off life to reach the 1 nanogram concentration. So how many minutes are spent from conversion of 4 nanograms to the 1 nanogram? It is 40 plus 40 minutes, totally 80 minutes. 80 minutes. So the answer will be here. Answer, how much time will it take to reach the therapeutic plasma concentration 4 nanograms to the 1 nanogram? So it is your option B, 80 minutes. Is that clear? Fine. So coming to the question number 8, the asthma patient with management on steroid-based therapy presented with a whitish oral thrush on the buccal mucosa as well as tongue. So what could be the preferred drug? So you need to treat the oral thrush. Here the best preferred drug will be your clotrimazole. Clotrimazole is the drug which is preferred for the treatment. So what about flucytosine? This will mainly going to inhibit the DNA as well as RNA synthesis, whereas glycofulvin will going to inhibit the microtubules, whereas terbinafine will going to inhibit the linosterol synthesis. Whereas the glycofulvin can be used along with the amphotericin B in case of the treatment of cryptococcal meningitis. So as you can see here, clotrimazole is a preferred drug. So how it acts? Clotrimazole, it is a ergosterol synthesis inhibitor. Ergosterol synthesis inhibitor. Basically, it will going to inhibits the which enzyme? It will going to inhibit the 14 alpha. It will going to inhibit the 14 alpha demethylase enzyme. So flucytosine inhibits DNA and RNA synthesis. Trisofulvin, they inhibit microtubular formations. They can be used in case of cryptococcal meningitis along with the amphotericin B. And whereas terbinafine is a lanosterol synthesis inhibitor which inhibits the sparine epoxidase enzyme. So coming to the question number 10. A patient presented to emergency after consuming 100 tablets of the aspirin. Aspirin is non-steroidal anti-inflammatory drugs. And what could be the best way to manage? So as you know that there is no antidote for aspirin. There is no antidote. There is no antidote for aspirin. Please remember, there is no antidote for aspirin. Then how will you going to manage the aspirin toxicity? So as you know that A for aspirin is the acidic drug. Please remember, aspirin is an acidic drug. To remove the acidic drug, what you want to do? You need to alkalize the urine. You need to alkalize the urine with the sodium bicarbonate. So thereby there will be more of the water soluble forms are formed which can be easily removed from the body. So here the answer is sodium bicarbonate. Sodium bicarbonate to alkalize the urine. So N-acetylcysteine is used to replenish liver glutathione. Mainly it is used to treat the paracetamol poisoning. So as you can see, aspirin is an acidic drug, and in case of acidic drug poisoning, you need to go for forced alkaline diuresis. For forced alkaline diuresis, you will be using sodium bicarbonate. Whereas for the basic drug poisoning like the amphetamine, morphine, you need to acidify the urine. And you can use ascorbic acid. So next, coming to the question number 11. So it is a case of gout, acute gout patient on anti-gout medication which act by decreasing the uric acid levels. So they're asking the patient is a acute gout patient on anti-gout medication. Which of the following drug act by decreasing the uric acid level, by decreasing the production of the uric acid? So which of the following drug will decrease the production of the uric acid? So it is again a tricky and direct answer you can make out. So it is a allopurinol, which is a xanthine oxidase inhibitor, which will going to decrease the uric acid synthesis, uric acid production. Whereas probenecid and sulfenpyrazine will going to cause uric acid excretion. They are also called as uricosuric agent. Whereas diclofenac will take care of the pain, acute pain, and colchicine is also an anti-inflammatory agent, will take care of the acute pain. So here the question is, they have asked acute gout and they're a little bit confusing you, and based on the next line, that is the drug which is acting by decreasing the uric acid level, by decreasing the production of uric acid, the answer will be here haloperidol. One more drug is the febuxostat. So the drugs inhibiting uric acid production is the drugs which can inhibit the acid oxidase inhibitor. The examples are the allopurinol and the febuxostat. Whereas the drugs which are increasing the uric acid excretion, which are also called as uricosuric agent, we have a probenecid and sulfenpyrazone. Sulfenpyrazone. Next, we have a question number 12, that is patient presented with arrhythmia and is on antiarrhythmic drugs, and he suddenly develops the pulmonary fibrosis. He develops a pulmonary fibrosis, and which is the probable drugs which has led to the development of the pulmonary fibrosis. So we have options like amiodarone, sotalol, verapamil, quinidine. All this can be used as antiarrhythmic drug. So here the drug which can cause pulmonary fibrosis is the amiodarone. Please remember, it is the amiodarone. So next, let us remember what are the drugs which are causing the pulmonary fibrosis. You can remember it as game, bleo, bus cycle. Game, bleo, bus cycle. So G stands for gold, A stands for amiodarone, ME stands for methotrexate, and bleo stands for bleomycin, bus stands for busulfan, and cycle stands for cyclophosphamide. So this is the mnemonic to remember the drugs causing the pulmonary fibrosis. So next, coming to the question number 13, a 3 months old patient or child presented with the paroxysms of cough. There is a duration of 3 months. There is a 3 months old. So there is a duration of 3 months history of paroxysm, cough, and apnea, and along with fever. He has a total leukocyte count of more than 50,000 with absolute lymphocytosis. Which of the following is the drug of choice for this condition? So paroxysm of cough and apnea, fever, increase in the leukocyte count will also, all this will suggestive of the infection. It is mainly due to the pneumonia. So here in the pneumonia, the drug of choice will be here. It is your azithromycin. It is your azithromycin. Azithromycin. Why not clarithromycin? Clarithromycin can lead to enzyme inductions. Enzyme inductions can lead to drug interactions. So next, coming to the 14th question. A diabetic patient with hypertension was started on angiotensin receptor blockers, ARBs. Which of the following is true? So let us make a statement before going to the options. So these are the correct statements actually. Losartan. So how we can remember TAN? TAN. So it is thrombocyte antagonist. So it is a thromboxane into blocker, losartan, which inhibit the platelet aggregation. Telmisartan, you can remember it as EL. So what is EL? It gets eliminated in the liver. So that is through the biliary excretion. Telmisartan will be eliminated through the liver. So it affects the liver. It affects the hepatic system, not the kidney, not the renal system. Whereas candicertan, you can remember C for C, kidney can. So candicertan will going to affect the kidney, but not the hepatic system. Whereas irbesartan, you can remember it as irrelevant. So there is no relevancy with the liver and kidney. Irbesartan will not affect the liver and kidney. So these are the true statements. So let us see the question. So which they are asking, which of the following is the true? Losartan is a competitive antagonist of thromboxane A2 and attenuates platelet aggregation. Yes, this is the true. What about telmisartan clearance is affected by renal insufficiency, but not in case of the hepatic. So they are basically affected in case of the hepatic. What we learned, EL, it gets eliminated by liver, so that therefore it will affect the hepatic system, but not the renal system. So this is the wrong statement. What about candicertan? Kidney can. So it is usually affect the kidney. So they are given. So clearance is affected by hepatic insufficiency. Wrong. but not in renal. Actually, it affects the renal system. So this is the wrong statement. What about the irbesartan clearance is affected by both hepatic and the renal insufficiency. Irbesartan clearance is not at all affected by both the hepatic and renal insufficiency. So the correct statement will be a losartan, which is a competitive antagonist of thromboxane A2, which decreases the which will attenuate the platelet aggregation. It acts as an antiplatelet agent, losartan. Next, coming to the 15th question, a patient of organophosphate poisoning was started an atropine infusion. Atropine is an antidote and pyridoxine is an antiactivator. He developed a high-grade fever after 2 hours. So which of the following is the possible cause of fever? So whenever you give a atropine, it will going to increase the body temperature. So it is called as atropine fever. So here the fever is mainly due to the side effects of the atropine. Side effects of the atropine. It is not due to the aspiration pneumonia or pyridoxine side effect or organophosphate poisoning. It is mainly due to the atropine side effect, atropine fever. So atropine poisoning, you will give atropine and pyridoxine. Atropine is an antidote for OP compound poisoning, and pyridoxine is the enzyme reactivator. And you can also notice the atropine fever. So coming to the 16th question, a pregnant female with history of bronchial asthma presented in a third stage labor. Which drug needs to be avoided in third stage of the labor? So you need to make sure that they are given bronchial asthma. So we need to check for these drugs have got any bronchoconstriction activity. So oxytocin doesn't have bronchoconstriction activity. Carboprost, misoprostol, and dinoproston. So dinoproston is a PG even analog, and misoprostol is also a prostaglandin even analog. So both of these are used in case of cervical ripening, whereas carboprost is a prostaglandin F2 F2 alpha analog, which can lead to bronchoconstriction. So which of the drug is avoided here? You need to avoid the carboprost. Is that clear? So carboprost is contraindicated. You can remember how. C, car for contraindication, contracts bronchial smooth muscles, and it is contraindicated. So misoprostol, PG even analog, and dinoproston, PG even analog, they are helpful in cervical ripening. Whereas oxytocin is a uterine stimulant, which is oxytocic agent, which can help in induction of the labor. So coming to the question number 17, in a patient who is planned for taking for a cardiac surgical procedure, which of the following is a preferred antibiotics? So basically they are asking about the surgical prophylaxis. So usually you'll use ceftriaxone. Which group of ceftriaxone are preferred for surgical prophylaxis? It is the first generation cephalosporins. So what will be the answer here? It is your cefazolin, which is the first generation cephalosporins. Is that clear? Fine. So surgical prophylaxis, you use cefazolin, which is a commonly used antibiotic from the first generation cephalosporins, which is used for surgical prophylaxis. So coming to the question number 18, a young female having a multiple sexual partner presented with vaginal discharge which showed an intracellular gram-negative diplococci. So there was a picture which was given and it showed a gram-negative diplococci. And what could be the preferred drug in this case? So please remember to treat a gram-negative diplococci in case of vaginal discharge. So it is mainly due to Neisseria gonorrhea infection. So that you are going to prefer is the ceftriaxone. So coming to the 19th question, 45-year-old female presented with epigastric pain, hematemesis, that is the vomiting of blood, melena, passing of blood through the uh, feces, with history of alcohol intake, and takes aspirin for her arthritic pain. So what could be the probable diagnosis based on symptoms? So her symptom is epigastric pain, hematemesis, and melena. So what could have caused? So she's taking aspirin. So aspirin, as you know, it is a platelet. It is an antiplatelet agent which prevents platelet aggregation and which could have led to the hematemesis and melena epigastric pain. And she has also a history of the alcohol intake, which can increase the risk of peptic ulcers. And this can lead to erosion of the peptic gastric mucosa, which can lead to erosion and it can rupture also. There can be rupture of the stomach, which can lead to bleeding. So probable cause will be for hematemesis, melena and epigastric pain is due to peptic ulcer disease, which has led to the peptic ulcer bleeding. So aspirin at low dose, 75 to 30 to 325 milligram, it will going to inhibit the thromboxane A2 activity. At these dose, it will act as an antiplatelet agent. So this will increase the risk of bleeding in case of, especially in case of peptic ulcer disease patient, which can present with epigastric pain, hematemesis and melena. So coming to the last question, that is, a patient presented with convulsion, opisthotonus, which of the following is the probable cause of drug poisoning? So there were some four option, but what we could get is the one main correct option, that is strychnine poisoning. So any of them, if you can remember the other option, can put it in the chat box or the comment box. So please remember the convulsion, opisthotonus. Opisthotonus means there is a muscle spasm which will lead to arching of the back, neck, and the spinal muscles. These are classically seen with the strychnine poisoning. Strychnine poisoning. So strychnine poisoning will have a classical symptoms of convulsion, opisthotonus, which is characterized by muscle spasm, arching of the back, neck, and spinal muscles. So this was all about the recall from the NEET 2023 examination. So if you have got any other questions related to pharmacology, please put it in the comment box and we'll try to make a proper question and the option so that you can expect these kind of questions in the upcoming examinations. Thank you.